So another gram-positive pathogen of importance is Strep pneumoniae. You can see on this gram stain that these are much smaller, even with it zoomed in, but it's because they're just diplococci, di meaning two. They're just in pairs of two here, and that's what's unique about Strep pneumoniae. Also, it causes a different group of infections, and so therefore if you encounter a gram-positive diplococci in a site where strep pneumo is a pathogen, then more than likely it's strep pneumo. And I'll just highlight the strep pneumoniae because this is the #1 cause of pneumonias and therefore is named as such. This is a nice up-close electron microscope version, and you can see these two cocci paired up here for the diplococci. And what's interesting in terms of nomenclature is this bug, because of its diplococci fashion, is known as pneumococcus. Whenever you see two diplococci, we'll talk about meningococcus, but whenever it's just two cocci, they carry this ending of coccus with their species name as the prefix. So pneumococcus is an example, meningococcus is an example for Neisseria meningitidis, and gonococcus is an example for Neisseria gonorrhea that causes the infection gonorrhea. Of course, this is one of these upper respiratory infection or colonizers. It lives in the nasopharynx, so when it escapes from there, as I like to think about it, it can cause infections. When it works its way downward, you can get pneumonias. If it works its way upwards, you get ear infections or in fact, meningitis. We do have a vaccine available that most of you all probably received as children, and that is the inactivated 23 serotypes included, the Pneumovax 23, and this decreases invasive infections, which means it decreases the incidence of bacteremias and decreases the incidence of meningitis specifically. Penicillin-resistant strains are often resistant to other classes, and so we usually term those drug-resistant strep pneumo. And again, this resistance does not equal an increase in virulence. So for example, if two people both get pneumonias with strep pneumo, one is resistant to penicillins and the other one is susceptible to penicillins, Dr. Wombwell, which one do you think will have the worst infection?
No, again, just re-emphasizing on your point, that resistance is not for increased virulence. It's still a strep pneumonia. We will just have to use a different agent to cover that infection. That's a great point.
Exactly. And, you know, when I think about respiratory pathogens, the atypical come into this realm. This is where we mostly encounter them. The Chlamydiaceae family, I refer to it as the family because there are the Chlamydiaceae that cause sexually transmitted infections. The one that you'll hear from us in the next few weeks is about Chlamydia pneumoniae, which causes pneumonias. And so you'll see a similarity among these pathogens that they all end with the suffix or the species name pneumoniae or pneumophilia, meaning that they're associated with pneumonias. And Dr. Wombwell also gave you a good historical perspective on Legionella and also referred to the Mycoplasma appropriately earlier. As we break these down, you can see them in this session about Chlamydiaceae. This is an intracellular parasite. So again, is that how come it does not gram stain?
Because it doesn't have the cell wall that we're typically seeing with our other gram-positive, gram-negative pathogens.
Ah, exactly. And here's the other species that you'll run into. Pneumoniae, as I've touched on. And another interesting one for your reference that you can learn more about it in our zoonotic illness course is Chlamydophila psittaci, which is a respiratory infection that's transmitted via bird excrement.
Pretty bird.
Pretty bird, pretty bird. So that brings us to the Mycoplasma pneumoniae. This is probably one of the more common encountered atypical pathogens. It lacks no cell wall, so again, it's difficult to gram stain and it's even more difficult to culture. This term fastidious is something that's applied to bacteria, which generally basically means that they need specific mediums to grow on. They're kind of picky bugs, you know, they're just not very friendly. They don't want to let you know they're there. And this is what we also call walking pneumonia, meaning that it might have just a cough for 4 to 6 weeks. It's susceptible to a lot of any antibiotics that cover the atypicals, but it's very low-grade pneumonia, and patients generally do well with this.
Yeah, and this is a point of emphasis. When we say atypicals, there's 3 antibiotic classes that we typically think about in terms of covering atypicals, and we'll cover all 3 of the atypicals generically as a class. So doxycycline, the macrolides, and fluoroquinolone. So anytime we have concern for any one of the atypicals, any one of those agents will provide sufficient coverage.
And what's that major class of antibiotics that'll never cover atypicals because of their site of action?
And that would be the penicillins or beta-lactams.
Yeah, so all beta-lactams, because they work at a cell wall And these bugs do not have cell walls. They are not active against atypical organisms. These other classes that Dr. Wombwell's referred to generally work on ribosomes or DNA. So keep in mind, even though a bacteria might lack a cell wall, they certainly have ribosomes to make protein synthesis and DNA, or else they would not exist. And just a little bit more on Legionella. The only thing that's here to highlight that we haven't talked about per se is this urinary antigen. And just keep in mind that a urinary antigen can be tested. So if the patient has an infection by Legionella, that antigen will be detected in their urine and show up positive, and then you can tailor your therapy specifically for Legionella.
Right, and one of the main things to remember is it's not like our culture and sensitivity where we get MICs back that are susceptible, intermediate, or resistant. This is simply going to give us a positive or negative. So there's the antigen is present or the antigen is not present.
Haemophilus is a gram-negative bacilli, so we're no longer talking about atypicals, but we've lumped it in here because of its nature of where it lives and the infections it causes. So respiratory infections, acute otitis media, and meningitis. Dr. Wombwell, do you know why I made the meningitis in a smaller font?
I don't know. Why did you do that?
Well, that's because ever since the advent of the vaccine for Haemophilus influenza, our rates of meningitis have declined dramatically. It used to be the #1 cause of meningitis, but since the advent of the vaccine, it is now the #3 or #4 cause of meningitis. Isn't it great that we have these vaccines available?
I think it's great that you know how to make these keys to help us remember these interesting little facts.
I wonder what Penn and Teller think about vaccines.
We should check out that video later. Penn and Teller on vaccinations. It's a YouTube video. Fantastic.
Yeah, these H. influenza often produces beta-lactamase, up to 50% of strains. So this is important to note that because of this, you will often have to use drug combinations that include the beta-lactamase inhibitors. So amoxicillin may not be active in some cases, but augmentin certainly will because of that beta-lactamase inhibitor. And again, I've already alluded to this, I've already alluded to this vaccine, which is for specifically the type B infection, the most invasive pneumonia strain. Most infections are treated empirically as opposed to direct coverage. And what I mean by that is most of the other pathogens that you're covering will also be somewhat resistant. So when you go to target strep pneumo, you will more than likely pick up your H. influenza. As though it harbors beta-lactamases, it doesn't harbor other resistance patterns per se.
Sure. So typically think of our respiratory agents such as fluoroquinolone, such as our beta-lactams. So generically we will assume that they cover H. influenza, M. catarrhalis, which we'll talk about here in a moment, as well as strep pneumo.
Yeah, so I like to call it strep pneumo's little wannabe brother. Wherever strep pneumo is raging infections, whether it be in your lungs, in your CSF or meninges, or in your ears, H. influenza is trying to get there too. Moraxella is an interesting bug because it's gram-negative as well. If you didn't know any better, you might think it's even gonorrhea on media because of its nature. The only difference is you're going to isolate it from a different site. This is a respiratory pathogen, whereas gonorrhea will be isolated from the genital tract. What's interesting about this is it generally causes these upper respiratory infections or acute exacerbations of chronic bronchitis or in COPD patients. It lacks virulence, meaning it's not really going to put people into septic shock or send them to the ICU, for example, or even cause pneumonias per se, but it can be sort of a pest for people with COPD if they acquire this illness. What's also cool about this bug is it almost always produces beta-lactamase, so you can never treat these patients with amoxicillin, but it's susceptible to nearly every other antibiotic other than amoxicillin alone. And so certainly the amoxicillin with clavulanic acid will inhibit this beta-lactamase ability to degrade the amoxicillin and make that one active as well.
Yeah, and as you guys probably remember from pharmacology, but just as a reminder, that clavulanic acid acts as a suicide inhibitor, so it directly goes and looks for the bacteria, gives up itself in a fashion that allows it to be bound by that beta-lactamase, so the amoxicillin is then free to exert its bactericidal effect. This is the same reason that we can use it in staph that encode for beta-lactamase, as well as H. influenza that we just talked about that encodes for beta-lactamases as well, and that is something that is increasing and something to be aware of.
So kind of in a review of these respiratory pathogens, they start with our gram-positive strep pneumoniae, the most common cause of pneumoniae, generally even regardless of setting, whether you acquired in the community, whether you acquired in the hospital, or within the healthcare facility, it's still our main focus and target. We got some of these other gram-negatives that come into play. The H. influenza, known as H. flu, or the M. catarrhalis, known as M. cat, are kind of minor players in this. They might produce some beta-lactamases, but generally not multi-drug resistant patterns. And generally, if you target the strep pneumoniae, you will have coverage for these agents as well. What we haven't talked about as far as the respiratory infections is the nosocomial pathogens. So when patients are intubated or on a ventilator, some of these bugs that live in their gut that are gram-negatives can migrate up and also cause pneumonias. And we'll talk about that when we talk about the Enterobacteriaceae. And then the atypical pathogens almost are exclusively associated with these respiratory infections. And so this is generally how I like to associate these and keep these in one group and keep the Streptococcus, group A streps, the Staphylococcus, and the Enterococcus in a whole nother ballpark.
Yeah, I'd say using this slide to think about your community-acquired respiratory infections is really great. So kind of set this slide aside and say, these are, if it's a community-acquired respiratory illness, these are the things I'm thinking of as possible pathogens versus if it's healthcare-associated or hospital-acquired.
So just to kind of review what we've been through, so far it seems like we've been through a lot. How about you, Dr. Wombwell?
Man, I'm getting a little tired.
I think
all this intellectual conversation.
I think my IQ just went up 10 points.
That's right.
So we've talked about the respiratory bugs. We just finished covering those. They include all classes. We got gram-positives, gram-negatives, and atypicals. We got the skin bugs that are generally just these twos, what we like to call the skin bugs, meaning that they cause skin and soft tissue infections that can be found on the skin, which is Staphylococcus, and then group A Streptococcus, and these are both gram-positive. And then we have the enteric bugs, which we're going to get into next. Enterococcus is the only gram-positive. Here's a fun fact about Enterococcus. Remember earlier when I said it looked like another one of these bacteria? Which one did it look like on a gram stain?
I think that was the Streptococcus, correct?
Correct. And in fact, it used to previously be called Group D Streptococcus.
How about that?
Yeah, but then they figured, you know what, this is really nothing like Streptococcus other than it appears in chains. It actually lives in your gut and causes a whole different course of infections, and its resistance patterns are drastically different. So we made up a new name for it. Now we call it Enterococcus, which better describes where it's located.
You're a wealth of information.
Thanks. We also have the Enterobacteriaceae. This is actually what we're going to go to next, and this is a whole family. So E. coli is sort of the spearhead of this family, but there are other ones included. So when you hear somebody talk about the Enterobacteriaceae, they are never talking about just one bug, but in fact a multitude of bugs that are found in your gut. The other bugs that are found in your gut are the anaerobic pathogens, and if we generally say gut anaerobes, we are worried about Bacteroides. And what you'll hear in class is that Bacteroides, the drug of choice, is Flagyl for that. That's because Bacteroides is known as Bacteroides Fragilis, and we like to say Flag for Frag. So as far as the Enterobacteriaceae, these are all gram-negative rods. These are the ones that are most likely to cause urinary tract infection, so often they'll be isolated from a urine culture that'll say gram-negative rods. Fortunately, most of our empiric therapy will cover these, so it just ensures us that we're going in the right direction. I've highlighted some of the more important ones. This is our major family of bacteria that are found in the gut. They are all gram-negative rods, and they're most commonly players in the urinary tract infection. So we usually see these in the hospital as part of a urinary culture that'll grow either E. coli, Proteus, or Klebsiella most commonly. Citrobacter and Enterobacter are slightly minor players with a little bit more resistance pattern. So the first three, E. coli, Proteus, and Klebsiella, are the ones you'll most likely encounter. The last few are going to be encountered in unique consequences where you might pick up Salmonella, for example.
Well, I think the fact is we really don't see Citrobacter and Enterobacter with any great extent in terms of the infections that we're seeing on cultures and susceptibilities. It's really limited to the E. coli, Proteus, Klebsiella, and rarely, if ever, do we see the Salmonella, the Shigella, or Serratia. Serratia sometimes, but really not very often. And the Citrobacter and Enterobacter are really limited to if it's someone who's been in the hospital for a while and they've picked it up as what we would call a nosocomial infection.
Yeah, I would agree entirely with that statement. It's important, though, to remember which ones all are encompassed within this family, of course, as well. So E. coli is our main one, our main Enterobacteriaceae. This one's a commensal bowel flora. That means that it's usually doing its thing in our gut and not really harming us. However, it can become an intestinal pathogen, such as the O5, O157 E. coli hemorrhagic strain.
Wow.
Or it can be an extraintestinal pathogen. So what I mean by that is when it gets outside of the intestines, for example, in your urinary tract or in your kidneys, then certainly it's going to cause an infection there. And this is #1 cause of urinary tract infections without a doubt in every setting. So that should be something that sticks with you guys throughout your careers. And then it'll also be encountered in other sort of abdominal infections like SBP, spontaneous bacterial peritonitis, or other intra-abdominal infections. One thing that I want to mention, but I don't want you guys to focus too much on, is this extended spectrum beta-lactamases. This is not to be confused with the run-of-the-mill beta-lactamases that are found in abundance in the majority of the bacteria. These extended spectrum beta-lactamases are generally at this point in time only found in Enterobacteriacae, notably E. coli and Klebsiella, and what this means is not only do they have the typical beta-lactamases, but they will even eat up the drugs that we have designed to combat them beta-lactamases. So therefore, a drug that includes a beta-lactamase inhibitor now will no longer be effective against that. And also our cephalosporins, such as our 3rd and 4th generation cephalosporins that should be active against gram-negative bacteria, will also no longer be active against that. Ultimately, what you need to know is that ESBLs will be rarely encountered in your career. If you do encounter them, they will be part of a urinary tract infection, most notably due to E. coli or Klebsiella, and the lab will often note that they are extended spectrum beta-lactamases. If you encounter a culture like this, and your lab notes that, the drug of choice to use are the carbapenems.
Yeah, I would 100% agree with that. Generally, as a student, what you need to realize is that ESBLs exist. They're specific to Enterobacteriaceae, and that our drug of choice are the carbapenems. There's a lot more in depth that we could go on this, but in order to not confuse you or to confuse the topic itself, limit your study to those 3 items there.
Exactly. We want to have intelligent conversation, and we want you guys to know about ESBLs, but they certainly should not be your focus. Your focus should be treating run-of-the-mill beta-lactamases and understanding the role of beta-lactamase inhibitors. Klebsiella is our second main player. What I like to say is wherever there's E. coli, there's Klebsiella right behind it. It's one of what we call the escape pathogens, which is a notation we'll talk about a little later that highlights some of the more resistant bacteria. Nearly all of these produce beta-lactamase, and as I've mentioned before, they might produce the ESBLs. Another thing just to commit for memory that you shouldn't focus too much on are the carbapenemases. I'll leave it at this. If you have a bacteria that produces a carbapenemase, we are in serious trouble as a society. They scare the heck out of me. What about you, Dr. Wombwell?
This is the stuff that gives me nightmares at night. I wake up sweaty, uncomfortable. I mean, KPCs, they're nasty.
KPCs are nasty. They leave us with only 2 other nasty antibiotics to use to treat them as well.
That's true.
Tigacycline.
Tigacycline and colistin. When you're down to tigacycline and colistin as possible therapeutic agents, you know you've got something mean on your hands. Tigacycline in and of itself has a black box warning that it increases mortality. There's increased mortality when you have to use it. So one, either you're treating infections that are really, really mean, or the fact that the drug itself increases your risk of dying, but it's the only thing you have to treat it is kind of a scary concept. And then colistin is almost like pouring bleach into your veins, is how I've heard it referred to. It kills everything, but it also kills everything. So again, just a really nasty drug.
Exactly. And just to talk about colistin for another second, what I think is funny about colistin is this is a polymyxin class. So all the other polymyxins, I mean, these are so toxic we only use them topically as part of some of your creams like your Neosporin, for example. And what's funny about this as well is that this drug is associated with severe nephro and neurotoxicity. So much so when the aminoglycosides came along, we thought the aminoglycosides were fantastic, and they still cause so much nephrotoxicity that now in 2012 we rarely use them. So this is like the aminoglycosides, but worse when it comes to toxicity. As far as KPCs, right now, fortunately for us, they're found mostly in Malaysia and Thailand. However, there have been some isolates in the United States. If you start hearing about this on the news, run for cover. It's worse than MRSA.
Yeah.
And so Klebsiella can be involved in UTIs, but it can also be called pneumonias for those people that are intubated or hospitalized, as it might migrate from your gut up through your lymphatic system and make its way into your lungs. And then there's another species that is less common, oxytosa, but Chlamydia or Klebsiella pneumoniae is the one that we see most commonly encountered clinically.
So Proteus is a very interesting species of bacteria, and most specifically for UTIs. And why is that kind of an interesting bacteria within UTIs?
Well, we'll talk about this a little bit in the UTI lecture, but I think it's important to know that this rod will split urease. So because of that, it'll end up with a more alkaline pH or an increased urinary pH on urinalysis, and possible even lead to stone formation or kidney stones. So if you encounter a patient that might have kidney stones along with their UTI or pyelonephritis, I usually put my money on Proteus. In fact, I have a running bet with all the physicians I work with. Whenever I see a pH of over 8 or 8.5, I bet everybody $1 that it's going to be Proteus in the urine culture. Have you ever done that?
No, but I bet you're a rich, rich man.
I've made $5 in the last week alone. Enterobacter is when we start getting grasping at straws. This is not one that you guys are going to encounter most commonly, but when you do, you'll encounter Enterobacter cloacae. And what we find is that this has so many resistance patterns that some of the most common things that you would think to use are not susceptible. For example, ampicillin or the aminopenicillins that are active against gram-negatives, our first-generation cephalosporins, which cover E. coli and Klebsiella, or even our macrolides are not going to cover Enterobacter. Main thing is, though, you'll usually encounter this in the hospital as part of nosocomial infections, as I've alluded to here. And when that does occur, just make sure that you tailor your regimen to its resistance pattern, and more than likely they'll be started on broad-spectrum antibiotics as part of this, either way, for empiric coverage.
Sure.
Citrobacter is kind of like Enterobacter's little brother. It's almost exactly the same. What's interesting about this is if you encounter it in the bloodstream, there might be other pathogens in the blood as well. And that's kind of unique when you think about bacteremias, which are usually monomicrobial. On the whole, Citrobacter and Enterobacter are the lowest players in this, and you should not commit too much time to focus on them.
Sure, yeah. If you do see Citrobacter, as the slide kind of details, it generally is polymicrobial about 50% of the time. If you see Citrobacter, it's usually in patients that do have a worse looking kind of outcome, or septic shock, etc., a worse type of infection.
So this is the Neisseria species. The Neisseria you'll encounter is part of the STIs. It's the number 2 most common STI, gonococcus or Neisseria gonorrhea. Next week, we're going to talk about Neisseria meningitidis, which is responsible for meningococcus, a very virulent infection that will cause high mortality rates associated with that. What's interesting is if somebody does get this Neisseria meningitis in its bloodstream, we refer to that as meningococcemia, and it's often very clear by the presentation of the patient. They will have this petechiae, these purple spots on their skin, very indicative of meningococcemia, and then often accompanies meningitis.
All right, so along those lines, we had talked about earlier how Pseudomonas aeruginosa is really our most pathogenic or virulent gram-negative. And so when we're covering for gram-negatives, it's usually directed by Pseudomonas coverage. Remember, this is a gram-negative bacilli. It's a rod, generally a nosocomial pathogen. And one of the key things to remember is its natural environment is moist environment. So if you have patients that have a foot infection and they've been in the water lately, then that would be a time where we're more concerned about Pseudomonas aeruginosa. There is this question about double empiric coverage, and there is some extending or new literature that says it's probably necessary in terms of giving us appropriate coverage initially, and then backing down once we know our susceptibility patterns, just down to one agent at that point. But that's something we'll discuss when we get to pneumonias, hospital-acquired pneumonias, within the lectures. Any other thoughts that you have, Dr. Caligiuri?
Yeah, sometimes I like to go to the hospital operator and ask her, can you page Pseudomonas, please, for me? And I just like to see the look on people's faces around the hospital when they page Pseudomonas. Pseudomonas, please. Acinetobacter is a bacteria that's kind of in the same family as Pseudomonas in that it's highly resistant and a nosocomial pathogen. Oftentimes, if you got a drug that is active against Pseudomonas, more than likely it'll be active against Acinetobacter, although resistance is increasing. What's another cool fun fact is that the beta-lactamase inhibitor sulbactam actually has activity against Acinetobacter, although it's not an antibiotic. So that's something good to know. And we're seeing a lot more increase in this, people returning from Afghanistan or Iraq, as they've picked this up as part of the war disaster areas. It's become increasing in prevalence. Stenotrophomonas is just really fun to say, so I added it in here.
I love saying Stenotrophomonas multiphilia. Stenotrophomonas multiphilia.
Stenotrophomonas multiphilia! As you see, I put that this slide is here for your reference. It's a gram-negative rod, and it's again a nosocomial pathogen. When I see this bug, it's usually in the cystic fibrosis patients that I work with who harbor resistant bacteria, this being one of them. This is generally not something you guys will encounter very frequently, if at all. That's why I put it here for just your reference. But what you should know, and what you should know for board testing purposes, is the drug of choice is Bactrim. It's almost resistant to some of our most broadest antibiotics, such as imipenem, aminoglycosides, or even the 4th generation cephalosporin cefepime. However, if you have a patient who's allergic to Bactrim, I often see minocycline employed, and every once in a while you might find a strain that's sensitive to levaquin even. But just keep in mind, Stenotrophomonas monas equals Bactrim treatment.
Yes.
And so we're going to close these series with the anaerobes, and there's only really two we're going to talk about, Bacteroides Fragilis and the Clostridia species. Bacteroides Fragilis is the most common anaerobic gram-negative rod. It's the anaerobe in that we don't even refer to it in its gram stain past that point. It is the anaerobe and is in all human colons. It is abscessogenic, and what I mean by that is it's likely to set up infections. If you have an intra-abdominal infection, Bacteroides could be the main player there. It's the most common cause of anaerobic bacteremias, and it can be part of polymicrobial intra-abdominal infections. This is often why you see combinations such as Cipro plus Flagyl used, so that the Flagyl component can cover the anaerobes of the gut. And again, Flagyl or metronidazole is the drug of choice, and then we use the term Flag for Frag. Clostridium is the other major anaerobe to speak of, and it produces toxins. We're going to spend a lot of time talking about C. diff, which is the infectious diarrhea. Here are the other species that are associated with Clostridium. These are also probably very familiar to you guys, although very rarely encountered. We have Clostridium perfringens, which causes gas gangrene. This will be a cellulitic infection that will literally produce bubbles and gas. There is the Clostridium botulinum, which is where we get the botulism from. In fact, this can be our friend if we want to do some Botox injections for wrinkles and such.
My, oh my.
Or migraines. I thought you were going to say migraines. And then there's Clostridium tetani, probably one of the most feared bacteria, at least for me. If you guys have ever seen a picture of somebody with full-blown tetany, it does not look like a pretty way to die. So make sure you guys are all up to speed on your booster shots. So we're going to end this with just some interesting things to keep in mind that go with the microbiology. And for those of you guys that have stuck with this intelligent conversation on clinical microbiology, this will be so much easier for you in the course and on the exam. So nosocomial infections are things that originate within the healthcare system. They are things that we need to avoid at all costs. They cost more money, and they're associated with a lot more length of stay and hospitalizations. Urinary tract infections are the most common because of our use of catheters. Essentially, when we insert a catheter, we are introducing bacteria, and they are at risk for urinary tract infections. I encourage all of you guys to check in on the status of the catheterization of your patients and remind everybody to pull those out at the soonest possible time when appropriate. Surgical site infections are another big deal. We'll use prophylactic antibiotics to try to prevent this. There are catheter-related bloodstream infections when we insert IV lines. We'll talk about that in class. There are pneumonias that can occur while in the hospital or while ventilated. And C. diff nearly always occurs in the hospital, although it's increasing in incidence in the communities, which is a scary thought. Infection control goes hand in hand with nosocomial infections. These are measures taken to prevent the spread of infections. Some examples where you might see some of this done is for patients that harbor MRSA, VRE, or these ESBL producers. We do not want other patients in the hospital to get these. Any patients that are positive for acid-fast bacilli, which suggests that they have tuberculosis infection, which is highly contagious, need to be isolated. Those that have positive C. diff should be isolated, as well as those with RSV virus or positive for influenza. The 10 by 20 campaign is about the last thing we'll talk about is these most resistant organisms. Basically, this is a campaign that is for 10 new antibiotics by the year 2020. These graphs show the increase in MRSA, the increase in VRE, and even fluoroquinolone-resistant strep pneumoniae over time. And it really speaks to the amount of resistance going on out there in contrast to the amount of antibiotics are developed. You can see that the lowest amount of antibiotics were developed between 2003 and 2007, according to this slide. The escape pathogens are the most resistant ones, and these are the ones we're trying to develop those 10 new antibiotics to target. Some of this will be a review because we've described the resistance patterns in detail in part of our intelligent conversation here. But this list includes some gram-positives, the E and the S, Enterococcus, Faecium. Remember, this is the most resistant species. And then Staphylococcus aureus. This should be no surprise to you guys. The MIC creep to vancomycin has to do with that clinical pearl we discussed regarding the MIC equal to 2. Some gram negatives on the list are Klebsiella and E. coli, and then the Acinetobacter. Again, we've told you guys about ESBL production and the KPCs. Run for your life if you see KPCs. Acinetobacter is increasing because of war and disaster, so watch out for this one as well. And then lastly, we have Pseudomonas, which we do have a fair amount of antibiotics that target Pseudomonas. However, it does have increasing resistance, and they may not always be susceptible to your empiric agents. And then Enterobacter, again, is a nosocomial pathogen. We talked about this in relation to Citrobacter, and just keep in mind if you encounter this, it's likely to harbor a big resistance pattern as well. So, to sum things up, there's a few other bacteria that you guys will encounter in the course as we keep going over the next few weeks. Pasteurella you'll encounter as part of bite wounds. There'll be some things unique to HIV and AIDS, as well as some other things that might show up in sexually transmitted infections. And we'll kind of end on these cool bugs. Some other things that we didn't talk about in depth and that would be interesting for you to look into. Bacillus anthracis is what we get anthrax from. Do you have a favorite on this list, Dr. Wombwell?
My favorite currently is Proteus. It's right now increasing in prevalence. We're up to over 30,000 cases since the start of the year, and that's as of October. When you compare that to previous rates, down around 7,000 or 8,000 per year, that's quite a big jump, and a lot of it is around the concern for people avoiding vaccinations or this vaccination waning problem where it used to be protective, but after 5 years that protection starts to decrease. And so it's just kind of an interesting topic to be looking at currently.
Yeah, I really like a lot of these pathogens as we talk about them in our zoonotics course. I like the Coxiella because I think Q fever is just a cool word. And then Burkholderia cepacia is one to note. This one used to previously be classified as a Pseudomonas species, but it is much more resistant and it's become its own genus and species on its own. I've seen this in a few of the cystic fibrosis patients we work with, and in fact it's so resistant that they won't let those cystic fibrosis patients around the other cystic fibrosis in patients in an event to prevent it from spreading.
Well, Dr. Caligiuri, this has been a super intelligent conversation. I've really appreciated having the opportunity to have this discussion with you. I think you've led us through some really interesting topics, made some very interesting points. I think it'll be beneficial for us all to review, not only once, but twice, maybe 3 times. Keep a hold of this video prior to rotations and after rotations, just as a good overall review on microbiology. So again, thank you for helping us out with this.
Yeah, it's been my pleasure. I really enjoyed doing this along with you so that we can talk about some of these cool bacteria and their roles in clinical microbiology and different thought processes that you have and I have when we encounter these clinically. And hopefully these will be beneficial for the students to think about and kind of stratify which ones are the ones that they should think most about, like Staphylococcus and E. coli, and which are the other ones they should put lower on their radar screen and that are okay if they only know the basics about, such as Stenotrophomonas or Enterobacter, because there are so many bacteria and it's tough to keep it all straight. So I hope this is helpful for everybody and they appreciate the intelligent conversation.
Sure. Thank you.
Thanks.